record on this computer. So it is the 14th. It is 1 month away from Bastille Day, like any of you cared about that. But I like history, so it's 1 month away from Bastille Day when they cut off Marie Antoinette's head. Vive la France. Exactly. Vive la Revolution. But yes, so we're going to talk about the ankle and the foot today for kinesiology. We also have a little bit to cover that in Therex tomorrow, but it's going to be pretty brief because most of what we're going to talk about is what we're going to talk about here today. So good news is Therex part of it's not as long. So if we're going to talk about this, there's got to be introduction. See what I did there? So the two main bones that make up most of the ankle are the tibia and the fibula. And one of the things I like to talk about when I'm talking about the tibia and the fibula, when we look at things, because we often look at the fibula and go, what the hell is the purpose of the fibula? The fibula's main purpose in our body is balance. We can live without it. We can completely function without it. But without it, we lose a lot of our balance function. A lot of our lateral stability of our ankle comes from our tibia or our fibula. So that's why we have it, right? And that's why when you look at stuff, that lateral malleolus kind of really sticks out there for us. It's also something really good to bang our ankles off of when we walk around the house, right? We've already covered most of the joint kind of parts, right? We covered the medial epicondyle, the lateral epicondyle, the crest, the medial malleolus. We've covered all those. Should be able to identify those all at this point. The fibular head, right, you find by just going distal to your knee, that knee space, the open space. If you go down, you find that kind of rounded area. That's your fibular head. It's pretty easy to find. Usually is a little bit painful because you have that fibular nerve right there. In between the tibia and the fibula, we have this kind of white gooey substance if you open up a human body, right? The stuff here. What is this stuff here called?
The interosseous membrane.
Yeah, the interosseous membrane, or the IM, good, right? And what we tend to forget, although we have that interosseous membrane there, we also have a little part down here at the distal end and a little part up here at the superior end. Now, also we have ligaments that lay over those. But there's a small part of the IMs that are in both of those parts as well. It's to hold those bones together. What kind of problems happens at that? What is our common issue that we get in this area? What's the condition we get when that gets all irritated? Shin splints, good, right? Good, so that can really kind of flare up. And, you know, I actually had that a few months ago when I was running because I got back to running longer than like 1 mile. And man, for about 2 weeks, oh boy, they were not happy campers. So once we drop kind of below that fibular head, we kind of get down into the malleoli, right? We drop down into the foot. And when we get down there, something's obviously a foot down there, right? Actually, the whole thing's a foot down there. We start with that calcaneus, right? That is our major kind of weight-bearing bone back there in the back part of our heel. And that's kind of the bone we can really feel. On the calcaneus, we have a couple really important parts. We have the calcaneal tuberosity. What's going to attach at the calcaneal tuberosity? Yeah, the Achilles. The Achilles, exactly, Achilles. I'm joking. The Achilles tendon, good. And then we also have this weird thing called the sustenaculum tali, which is this spot here in between the calcaneus and the talus, right? It's kind of the part that holds those two together. So sustenaculum tali. You can't really palpate that for the most part, but it's kind of that spot between them. And it's kind of important to know because sometimes we can end up with problems there. We have our big talus, right? Which also means talon in good old Latin or Greek. I don't remember which one that comes from, but that's kind of the talon or the hook that hooks onto the rest of your foot bones. We have our navicular. Our navicular is really important. Why is our navicular important to physical therapy? What does it give us that we can locate on the foot?
Arch.
Yeah, it helps with the arch. And what's the bony landmark we can find?
Uniform.
The navicular tuberosity, right? Okay, got something. The tube, yeah, right? So if we come down there and we find our big toe, we kind of trace our way back until we find the calcaneus. and we come a little bit forward from the calcaneus, you're able to find that kind of bumpy substance right there. That's our navicular tuberosity. Why is it important to be able to identify that? When we measure the ankle, right, for that figure 8 measurement you learned last semester in modalities, we use that as one of our landmarks. So you've got to be able to find that navicular tuberosity there to find it. As we cross, immediately across from that, come lateral to the navicular, we come across the cuboid, right? And the cuboid is named because, guess why? It's named for its shape. It's kind of cube-like, right? That cuboid can become problematic because that cuboid likes to slip out of its spot quite frequently. Has anyone ever subluxed their cuboid before? Where they've had to do what's called a cuboid whip on it and pop it back into place? No one? Huh. Impressive. Usually at least one person. Mine likes to pop out quite frequently. And some of you actually may have a cuboid that's slightly out of place and not even know it, especially if you kind of get pain on that lateral foot when you walk. Well, what causes it? Well, so when your lateral ankle kind of becomes a little bit weak, Riley, that cuboid likes to kind of shift up and down a little bit more than it should. It has a natural up and down play, right? As you plant down, it kind of pops up, right? As you put weight through it, and then it'll kind of push down to help you kind of get that spring off as you walk. But it can kind of slip down, and what happens is, let's see here. So there's my cuboid, right? It kind of shifts down just a little bit, and what happens when it shifts down, it starts bumping back here on the back part of those mets, or that met particularly, and it just feels uncomfortable. I notice it when I'm walking, when I go through roll off and kind of roll through my foot, I get kind of a stinging, achy feeling in that lateral aspect of my foot, and that's usually because my cuboid has slipped a little bit. And when it slips, all you do is kind of get on it, and then you can actually just pop it really quick. There's a couple techniques for it. And it pops right back into place, and then it usually doesn't bother you for a little while. For me, what usually causes mine to kind of slip is when I do a lot of like lower leg exercises. So when I do like, toe presses or stuff like that, for whatever reason, that triggers it to kind of pop out on me. I think just because of the pull of all the tendons and that. I have no empirical evidence as to why it happens. I just have some anecdotal. And then just kind of cradled in the cuboid and ahead of my navicular are my cuneiforms. So a lot of times they're labeled first, second, third cuneiform. I really don't like that. Because for me, I always had a hard time remembering which is my first, which is my second, and which is my third, right? Because I could never remember, is my first on my medial side or is my first on my lateral side? So I tend to prefer calling them the medial, the intermediate, and the lateral cuneiform. To me, that makes a lot more sense. I don't know about to you guys. But when I look at this, if I remember that my medial is my first, that helps me then. It is easier, right, Oscar? Yeah. But then what happened if I remember that I've got a medial, if I remember that my medial is my first, that helps me remember if something else is listed in the 1 through 3 cuneiform region. So that was my way of remembering in school, is my medial is number 1. And then I go 2, 3 across. I prefer, and usually when I'm going to talk about these, especially in thorax, I usually call them the medial, the intermediate, and the lateral cuneiform, just because that's the way my brain works. And it's a scary place up there, right? So once we come down from them, we come out of that part of our foot, the next thing we come to is the mets, right? The metatarsals. And believe it or not, the first and the 5th metatarsal of our foot, yeah, you can remember them that way. Good point, Amanda. That would have been logical. Thanks. Thanks for proving me completely illogical. Appreciate that. I didn't, you know what? I'll be 100% honest. I've been in the field for how long? I don't even know, 2007, and that never really clicked with me. And now that you say that, that makes so much sense. I don't know why that never hit. It hit now. Ding, right? Yeah. I still probably remember in my way, but I appreciate that. The first and the fifth of our metatarsals bear most of our weight because of the way our arch is set up, right? So those are kind of our weight-bearing metatarsals, especially our first metatarsal. I always get confused, at least, I don't know about you guys, but I always got confused about what was a base and what was a head of a metatarsal or a phalange. Does anyone else kind of get that confused?
Would the base be like proximal and wider?
Yeah. So, yeah, exactly. She's right. Base is proximal and wider, but that doesn't mean, I mean, I just realized the cuneiforms lined up with metatarsal. So for whatever reason, this was another hard thing for me. It was understanding which was the base and which was the head. So what I always remembered, we're going to talk about that in a second, Anthony. So you're almost there. You're almost there. What I always remember when I was talking about the base and the head was, I always remember that the head was farther away, right? When you talk about the body, the head's the farthest part of the way from the body. The head of the metatarsals is always the farthest away part. I don't know why that was such a problem with me. Maybe I'm an idiot, and you guys may be going, yeah, you know what? None of this really bothered me, Mr. McKeever. Well, it may have bothered me, so I always had a problem remembering which is that, right? So our metatarsals have a head and a base. The fifth metatarsal also has a tuberosity, right? And that tuberosity is kind of a little hook here, right? That fifth metatarsal has a hook or a tuberosity on it. It kind of comes backwards just a little bit, as you can see here in this picture over here, where it kind of dips back a little bit. And again, when we have those, that's just because those bones have muscle attachments. That's why they're there. And then we have our phalanges, right? We have 14 phalanges. And some of you will argue that, well, I don't have those, all three of those in my little toe. You do have them. They may not feel like it. Like if I take my middle toe or my little toe, I'm not sure that I have a proximal, middle, and a distal phalange. It kind of feels like I just have mush out there in my little toe. But they do exist. The bones do exist if you x-ray them. The big toe is kind of our major one because our big toe kind of controls our push off. But it's funny when we have somebody that's got something like diabetes or something like that, where they get an amputation of maybe the little toe or the digit 4 or digit 5. It's amazing how much balance they lose when they lose that little toe. And you would really think that there's nothing there. But all of us have experienced this where we bang our little toe off the coffee table or off the corner of a wall. And then for whatever reason, it feels like for the rest of the day when we're walking around, our balance is off because we're trying to keep weight off that little toe. That little toe does do some balance work out there. It may not seem like it does, but it does. So when we talk about the foot, because Anthony was already kind of on this process here, he was ahead of me, right? We divide the foot up into 3 sections. We have the hind foot, the midfoot, and the forefoot. The hind foot is our calcaneus and talus. The midfoot is our navicular, cuboid, and cuneus. And our forefoot is our metatarsals and phalanges, exactly like Anthony was going, right? That's important to understand because that comes into play with our arches, right? So we have to be able to split it up nice and evenly. The other thing is, in surgeries, we have a forefoot amputation, which amputates just those. We have a midfoot amputation that amputates those. And then we have some partial hind foots where we might only amputate the calcaneus, or we have a full hind foot where we amputate the full foot itself. So that would take everything off. So that's the part of the reason why we separate these into different areas is mainly for surgeries, right? So sometimes we'll fuse different areas as well. There's nothing to be sorry about, by the way, Anthony. You're just way ahead of everybody. So the ankle joint and foot perform 3 main functions. The main function of the foot, I'm going to be 100% honest, is shock absorption. That is the point of our arches, right? As we plant down, it's supposed to transfer a little bit of that force as we plant down across the foot. So the forefoot, right? Forefoot is everything from the mets up. So the metatarsals and the phalangeals. So basically all the big bones in the distal end of your foot. So forefoot is distal, hind foot is more proximal, if that makes sense. So again, hind foot, calcaneus, and talus. midfoot, all the little bones, right? Navic, cuboid, cuneus. And then forefoot are the mets and the phalanges.
Did you say it was the midfoot that does the shock absorption?
It's going to be the midfoot's going to be one of the main part that has the arch, right? And so, yeah, it's going to be really key for shock absorption, for sure. Now, obviously, the heel's going to have some shock absorption as well because we're going to plant down on it, but not nearly as much as through that midfoot. The other thing the foot does, yes, hind is behind, forefoot is forward. That works for you. That works however you remember it. I like that, John. I probably remembered that a long time ago, but I'm old. The other thing is adaption to the ground level, right? And we've lost a little bit of this with the fact that we now walk around in shoes most of the time. But I'm a weird person. I like walking around barefoot a lot just because I find that it helps with my foot pain when I walk around barefoot because my foot kind of conforms to the surface I'm walking on and I can feel my whole foot. So the job of the foot is to kind of conform. If we're walking on gravel, the foot's going to feel a little different than walking on grass, which is going to feel a little different than walking on dirt. The foot's job is to kind of adapt to that. It also provides a strong base support for propelling the body forward. We have a couple of different motions. We have plantar flexion of the ankle, right, and dorsiflexion of the ankle. That occurs in the sagittal plane, goes up and down. We have inversion and eversion, which occur in the frontal plane. That's turning the toes in and turning the toes out. We do have adduction and abduction and supination and pronation of the foot. I'm going to be 100% honest. Your boards are likely not to ask you a ton about adduction, abduction, supination, pronation of the foot. So breathe a little bit of a sigh of relief because there's a lot of arguments when it comes to adduction and abduction, supination, pronation of the foot. Because what they say is, well, adduction and abduction of the foot isn't really true foot motion. It's more hip motion because it's literally rotating the foot. And that's more truly at the hip. And then they'll also say that supination and pronation aren't really motions. They're combinations of motion. If you look, supination is plantar flexion, inversion, and adduction, right? That's a lot of combinations there. I am not going to make you memorize what supination and pronation of the foot are. So, thank you, Mr. McKeever. But understand that if you're in a clinic that specializes in feet, a lot of the people that really specialize in feet will say that all these motions occur, and you might have to know that. So especially a clinic that specializes in helping runners, they're really big on looking at that supination and pronation of the foot. Yeah, technically supination and pronation would occur in all planes. You're 100% right. You would almost consider those more of a rotational movement, right? If you look at the way it's kind of going through things, it's more of a rotational movement than anything. Yeah, because we have plantar flexion in the sagittal, we got inversion, eversion occurring in the frontal, and then transverse, we got that adduction, abduction. For sure. Yes, John.
Yeah, that's the one you're talking about, like when you're talking about like running and like hitting like the outside or inside of your foot, correct?
Yep, exactly. Right, hitting the outside being the pronator, right, and then hitting the inside or inside being pronator, outside being supinator, 100%.
Okay,
right?
cool.
Which
Thank you.
it's the Ann's question, right? That they all occur in all the planes of the foot. So, if I have Ann, maybe I analyze her gait, and I notice she's a heavy pronator. Well, I know that pronation is a combination of dorsiflexion, eversion, and abduction, right? So I know she might be tight in those muscles if she's kind of overpronating. So then I'm going to try stretching her in the opposite motions, right? I'm going to stretch her into plantar flexion, inversion, and adduction to see if I can relieve some of that and maybe even out her foot a little bit. It's really important for runners to look at this just because, obviously when we're running, I mentioned this before, we want some slight pronation, right? Running on kind of the inside of the foot to help with shock absorption, but we want it as neutral as possible. Lots of pictures here, just because I want to do a bunch of pictures. Excuse me. So remember what I mentioned at the calcaneus, we can have what's called a neutral, a varus, or a valgus calcaneus. They match up with which other joint?
The knee.
The knee. Good. Right? So if I've got genu varus, I'm probably going to have calcaneal varus as well. So they're going to kind of come into play. The far pictures over here are my varus valgus of the calcaneus. So neutral, just kind of the foot falls right down the middle. Calcaneal valgus, it forms that L. And again, what I remember is calcaneal varus gets this. And if you look at it, it's kind of backwards of the knee, but we're not looking at the way the kind of ankle puts. It's this motion here, right? So if I've got both of those, the ankles are kind of very far apart. Whereas if here, the ankles are kind of forming a knock ankle, if you will. So here's lateral, right? Here's medial when you're looking at it.
So that's a posterior view then?
That would be a posterior view. You're 100% right. Yep. So when the calcaneus kind of shifts to the lateral aspect, we're looking at a valgus foot. When the calcaneus shifts more to a medial aspect, it's a varus foot, but it's more about the angle that's formed on the varus versus valgus type motion.
So you said that the valgus is the ankles are knocked?
Yeah, so valgus, the ankles will form. So let me get a different color here so I can draw a little better, right? So if I have here's my kind of tibia coming down, right? And I have a valgus, my calcaneuses are going to be further apart, but those ankles are going to kind of come together like that at the angle. So they're going to be kind of knocked together, just like they would be up here at the knee.
So they're going to kind of go in medially. That's what you were saying?
Yes, they're going to go medially. So those medial malleoluses would be closer together.
And that causes a pronator runner?
It could, in theory, yeah, absolutely. Again, what causes pronator runner a lot of times has to do more with muscular imbalances than it does bony imbalances, but that absolutely could.
Okay.
Right, that'd be one where that's one, again, the foot and the ankle. So here's my personal opinion. The foot and the hand are probably the most complex structures we have in the human body.
Mm-hmm.
Because that's going to be one a lot of times when we're treating them that we kind of have to try the shotgun approach and throw everything against the wall and see what sticks. Because we may think it may be calcaneal valgus or varus, and it turns out that instead it's just muscle imbalance.
Okay, and that was the valgus, correct?
That would be valgus, right? Whereas varus, the medial malleolus are going to be a little bit further apart.
Okay, thank you.
Yeah, no problem. And again, remember that valgus and varus, for the most part, and a good rule of thumb is they line up with the knee. So if you have varus at the knee, you have valgus or varus at the ankle, and then your hip is the opposite one. A couple joints, we have our talotibial joint, right? This is the talus interacting with the tibia. It is a uniaxial triplanar joint, primarily only allowing dorsiflexion, plantar flexion. We have our subtalar joint, which is the joint underneath the talus, subtalar, where primarily our inversion eversion occurs. We have our transverse tarsal, so the bone's going across the foot. That helps with inversion and eversion and also creates that kind of supination, plantar flexion, and adduction motion, or eversion, the pronation, dorsiflexion, and abduction. What I want you to know there is that the plantar flexion, dorsiflexion occurs at the talotibial, and our inversion and eversion occur both at the subtalar and the transverse tarsal joint. So where they come across the foot. It's kind of important to know just because that way you can kind of feel and know what's going on. If a patient has a problem at that with plantar flexion and dorsiflexion, we know that it's primarily occurring at that talotibial joint.
And why is it triplanar?
So it's going to be triplanar because we have how many bones interacting at that point? Even though it's talotibial, we also have the fibula there that's kind of keeping everything stable,
Okay.
right? And that's just kind of the way they look at it. Again, more important to me is not necessarily the triplanar. More important to me is knowing that it's uniaxial, and that's where our plantar flexion, dorsiflexion occur. So when your boards come, they're not going to ask you the planars per se, but they would ask you where plantar flexion, dorsiflexion occur at the foot, and that's going to occur at the talotibial joint.
Okay.
And that's kind of why I'm stressing those two, is because I know the board questions on those typically are, where does this occur? Where does plantar flexion, dorsiflexion occur? And where does this occur? And so plantar flexion, dorsiflexion, talotibial, inversion, eversion occurs both at kind of that transverse tarsal, so that joint going across the tarsals, and the talo or the subtalar joint, the joint underneath here where the talus kind of meets the calcaneus. That's a lot of drawing in red. I feel like I'm marking papers wrong. So when we get out to like the metatarsal phalangeal joint, the greatest range of motion in the foot occurs at the first MTP joint, metatarsal phalangeal joint. And that kind of makes sense. We do most of the motion at our foot at that joint. I mean, try to really move your little toes by themselves. That doesn't really occur, right? But you can move your big toe for the most part by itself. The other toes go along with it, but you can pretty much move your big toe by itself. You also have the PIP and the DIP out there, right? Or with the big toe, you only have that IP, right? Interphalangeal joint. For the toes, we have flexion and extension. We know that. And we do have a little bit of hyper-extension when you go way back, right? I wish with the toes, they would just stick with dorsiflexion and plantar flexion. To me, that would make sense. And again, this is the book saying that extension is when you come to neutral. I'm trying not to make that distinction, and you'll see on your quiz question, there's actually a question about extension or flexion, and I'll say that extension includes this coming up, right? They'll say that extension is just kind of returning to neutral from flexion, but again, different books will argue that and say that extension is coming up with the toes. Flexion is going down with the toe, obviously. You do have some ab and adduction, spreading your toes apart, not nearly as much as you would have at the hand, right? When we get out to the little parts of the toes, the dips and the pips, we primarily only have flexion and extension. They can kind of curl or they can kind of go back. If you would have problems with extension of the toes, could that cause problems with gait? Like if your toes get stuck in flexion?
Yes.
Yeah. Right. Think about that. If your toes are constantly curled, you're going to be constantly banging them down every time you go through you come down, roll through heel strike, roll through the foot and try to get push off. You're going to be banging those toes every time. And again, most of the motion when you're looking at the foot honestly occurs at that first joint. That big toe does a lot of work, right? And some of us have even trained our big toes that we can use this space in between the first and the second toe for picking up, right? I don't know how many of you do that. I'm weird like that. I use my feet to pick stuff up off the floor all the time. My feet are clean though, thank you, before anyone says anything gross. All right, the joint capsule. Remember, I said, and we're gonna talk about capsular patterns coming up, but the capsule is kind of what holds everything together. And this is why the ankle is such a hot mess. Because look at this. Does this look like a hot mess to you guys? It looks like a hot mess to me. There are so many freaking little itsy bitsy ligaments that are in the ankle that I'm like, wow, no wonder we sprain our ankles so much. Right? I'm just looking at this going, wait. I've got a tibio-navicular that goes along with the tibio-talar that goes along with, right? I'm just like, wow, there's a lot of crap here, is the best way to put it. The good news is that anterior, the AITFL, anterior inferior talofibular ligament. Yeah, that's kind of, where's that one at? There's anterior talofibular. So It's part of this anterior talofibular ligament, so there is part of it. We kind of don't separate them out as much as we used to. But that's what I kind of want to talk about. When I'm talking about the joint capsule itself, most of your board questions and most of the questions I'm going to ask you are going to divide them into two sections. Your deltoid leg and your lateral legs. Deltoid is kind of on the inside, right? And lateral legs are obviously on the outside. When you have these, one of the most important ligaments we have in the foot is this one right here, this spring ligament. What do you think that spring ligament's job is?
Like,
Good, it's okay, guess, Brooke.
I'm trying to see how the foot, is that on the medial side?
That's on the medial side, yes, it's on the tibial side.
I don't know. I thought it was a lateral, but I guess I'd say like to not like sprain medially. I don't know.
Well, so let's think logically in the name. It helps with, there we go, Amanda's got it. It helps with propulsion, right? And it also helps form the arch like Anthony said as well. So that spring ligament's main job is when you kind of flatten down to help pull that foot up kind of in a spring motion. It's really important for when we do stuff like jumping, right? Right, jump around, jump up and get down. Oh, wait, no. It's really important because it kind of forms this bridge here between the navicular and the calcaneus. And that's kind of on our stable side, right? We consider the medial side a little bit more stable and the lateral side a little bit less stable because there's more ligaments on the medial side. This is why it's a lot harder to get an eversion sprain versus an inversion sprain. So when we're looking at the foot, right? So if here's my foot, and this is my lateral aspect, and this is my medial aspect of my foot. We typically roll our foot inward, right? And so when we sprain the ankle, we name it based upon the direction the foot goes. So if we roll our foot inside, that is an inversion sprain because you're turning your foot into inversion. Versus if we roll it kind of outside, that's called an eversion sprain. An inversion sprain is the most common sprain you'll get because, again, looking at that lateral aspect out here, to me, those ligaments look a lot tinier and there's a lot less thick of them, right? It's not like they're all kind of laid over each other. Yeah, I saw that actually. Inversion sprains will affect lateral ligaments. Very good. I'm starting to get scared by you guys because you're reading my next thing I was literally going to say. Get out of my head. It's a scary place up there. I mean, there's a lot of room up there. Evidently, you guys are renting space. I'm just saying. But yes, so when you have an inversion sprain, the lateral aspect gets the injury. When you get an eversion sprain, the medial aspect gets the injury. And most of the time, if you happen to be lucky and get one of those eversion sprains, it's typically either this tibio-navicular or the spring ligament that gets hurt. And when this spring ligament gets hurt, that's a lot of problems with propulsion. Like, yeah, Kyrie Irving got, and they're worried about what he did to his ankle bad because that was not pretty. Yeah, he could, that could, and with basketball players, ankle sprains, I don't know how many, I'm sure a lot of you play basketball, and I'm sure a lot of you have sprained your ankle, but when you sprain your ankle, it seriously messes with your ability to play basketball. You know, we're going to talk about high ankle sprains in thorax, so that's even kind of worse. Those injuries just suck. Well, why does this happen? Well, the fibula is out here. The fibula is kind of a tiny bone. That's why that lateral aspect just doesn't have the stability. If we probably had a bone out there that was the same size as our tibia, we may not sprain that side, but then we wouldn't have as much mobility at the ankle either. So with your boards, do you have to be, are you needing to diagnose, know what the deltoids are, what the laterals are? Spring ligament right? Spring ligament is on tibial side, so spring ligament is medial. Right, so this is my medial view and this is my lateral view. If that makes sense. That's what I was actually going to talk about right now, John. So when your boards ask you questions, they may ask you on what side of the foot does X ligament occur at. Okay, so they might say on what side of the foot does the tibio-navicular ligament occur? Well, that's when you go, oh, well, it's coming from the tibia and it's going to the navicular. That's got to be a medial ligament because tibia is on the medial aspect, right? The good news is all of the ligaments are named for where they start to where they go. So tibio-navicular, tibia to the navicular. Tibio-talar, tibius, right? The tibia to the talus. Posterior tibial talar. Well, it's on the back side, right? The tibio-calcaneal, again, another medial ligament. Why is that important? So the boards might ask a question like this. So let me get my little text drawer up here, and we're going to go with, let's go with orange writing. Let's see how orange writing looks on this. Your patient suffers a tibio-talar ligament grade 3 sprain. The direction patient likely sprained their ankle in is what? So they'll come down here and go inversion, eversion, flexion, extension. So when you're looking at that going, oh, well, flexion and extension doesn't make any sense, so I'm going to rule those two out. So the next thing, good, right? So Amanda's already on it, right? She's already got an eversion, right? So the next thing I'm going to do with this question and go, okay, so I've got a tibio-talar ligament. So tibio-talar, if it's a tibio-talar ligament, it's got to be on the medial side. If I have a medial sprain, I had to have gone into eversion because that means I had to turn my foot and lift that kind of lateral aspect of my foot up. I got a question coming in.
Yeah, I don't get that.
Okay, that's why I'm going to beat that into your head right now, Brooke.
Okay.
So let me see if I've got a better picture of a foot here from one of the previous ones. Clear my drawings.
I mean, would you be able to kind of demonstrate it with your foot?
Sure. Yep. Let me ignore my compression hose. I look like an old man, but sure. Let's change cameras here. All right. So that's why I've been wearing shorts a lot, is because I know that we've been getting into this. So if I get an inversion sprain, when I plant down, I'm rolling my foot like that. Right? So my foot is kind of rolling inward. I'm going in, because if I do inversion, I'm going like that, right?
Yes.
So when I go like that, that's an inversion sprain. When I do that, all of that lateral aspect of my lateral foot is being stretched out as far as it possibly can be stretched out. That means all of those little, the talotibial, the inferior talofibular, all those are being stretched out as far as they can. So those are going to be the ligaments that get sprained if I do an inversion sprain. I probably can't even do an eversion sprain because I have no eversion. But an eversion sprain, right? If I go eversion, I'm going up and out like that. So, and the only times I've seen those people like that push off really hard with that foot and kind of do something like that, like a basketball cut or a football cut. At that point, when I do that, all of these ligaments on the inside of my foot are going to be stretched, because if I take my foot and move it into eversion, all of these ligaments in here are stretched out to the absolute max. So it's an easy way to remember it. Yes, Amanda got it. Yes. Deltoid ligament is medial. An easy way to remember it is if I do an eversion strain, I'm going to strain the deltoids, the deltoid ligament. And remember, it's not this deltoid muscle that's up in our arm, it's the way it's shaped. Right? If you look at this, this looks a lot like the way our deltoid is shaped up top, right? If we do an inversion strain, we strain all of our lateral ligaments. So in that question I asked, when I had asked it, I had asked about the tibiotalar, I think, or something like that. Which ligament did I say? Did I say tibiotalar? I can't remember. Anyway, I think I said tibiotalar.
Yeah, you said tibiotalar.
Thank you. My brain, I deleted that on accident, right? And so that's when I go, okay, so I'm going from the tibia to the talus. If I'm going from the tibia, it has to be on my medial side of my ankle. If it's one of the medial side of my ankle, it's part of the deltoids, and therefore it's an eversion strain. If I said something like the talofibular, well, fibula, lateral aspect of my ankle, then I'm going to have a lateral ligament strain, which means it's an inversion strain or sprain. And I gotta get better at doing this. Sprain.
I'm just confused why it'd be eversion.
Okay.
Because it's your foot is going inversion.
My foot would be going inversion if I'm shortening them. If I'm lengthening them, I'm going into eversion. Because think about it. So here's all those ligaments, right? Right in this little capsule here.
Mm-hmm.
In order to stretch them, if I bring it into inversion, all those are shrinking.
Okay.
So they're not getting stressed at all,
No.
right? But if I go into eversion, all of those ligaments are now stretched out to their max. And that's when you usually sprain those ligaments, is when they're on stretch. You don't sprain them when they're shortened. So the best way I can maybe explain this, Brooke, and maybe we just have to do some drawing a little bit together and stuff like that, is if the ligament is on the medial side, so on the inside of the foot, it is an eversion strain sprain that's going to cause it. Yes, ligaments that are being stretched excessively are the ones being sprained, right? So if I have an injury to a ligament that is somewhere on the inside of my ankle, that's going into eversion in order to cause it, because it has to be stretched out and pulled apart in order to actually sprain it.
Okay, that makes sense. I think I'm just thinking of the question that you were typing. I think I maybe read it wrong or something, because I thought it was the opposite of how I was reading it. I don't know.
Okay. We'll put together some more questions on it, work through that. Don't worry.
I understand everything you're saying, so maybe it was just me with the question.
Been just reading the question, and we're actually, there's a couple of those practice questions that I have. So, because we're going to do a little bit of that this semester in order to start getting you guys prepped for the boards. And there's a couple on this that will come up.
Okay, and then the deltoid ligaments are on the what aspect?
Deltoids are medial aspect.
Medial, okay.
Right? And then lateral are obviously, well, it's in their name, lateral, right? They could call these the medial ligaments, but because of their shape, they call them the deltoid ligaments.
Okay, all right.
And honestly, I looked last night, I was curious, and evidently in like England, they call them the medial ligaments. So I guess we're just weird, I don't know.
Okay.
Because we like to be cool and be like the rebels without a cause. And here's the deal, Brooke, is if you're not getting it, you're not the only one. So I appreciate you asking questions. So don't ever think that I'm ever going to chastise you for asking questions.
Oh, yeah. No, thank you. I appreciate it.
Let me switch back away from looking at my butt. And yeah, so Amanda brought up a good point. Move your foot around. It will help you feel it on your own ankle. If you take your foot and really torque it into inversion, you can feel those lateral ankle ligaments being stretched. Or if you go the other way, which I can't even do, I can kind of get a medial strain, but I'm so tight in the eversion, I'm not likely to ever injure that. So again, just remember that if we have an eversion sprain, it's the medial ligaments or deltoid ligaments. If you have a lateral sprain, it's usually an inversion sprain. That's fine. If you want to twerk it, you can twerk it, right? I think Missy Elliott said we can twerk it, right? Didn't she? It's got to twerk. When we talk arches, we have two different arches primarily. And again, it says arches, but primarily we have two different arches. We have our longitudinal, meaning the length of the foot, and then we have our transverse, meaning going across. The length of the foot kind of runs, in general, what you say is the length of the longitudinal arch typically will say runs from the head of the first met back to the calcaneus. That's kind of our longitudinal arch. Versus our medial arch or our transverse arch goes across those cuneiforms and the cuboid. It does not include the navicular. The navicular is not part of the arch itself. That is a question I've seen pop up a few times where they'll say, which of the following bones does not make up the transverse arch? And they'll say the first cuneiform, second cuneiform, third cuneiform, cuboid, or navicular. Navicular is not part of the arch. The navicular is more of a bone out there for stability and muscle attachment. So the cunees are there mainly for the arch. Even honestly, to be 100% honest, that's a great question. It's Truman asked, not part of either arch. If you really look at it, the navicular is not even really part of the longitudinal arch. It kind of sits up and out of its own way. The main part of that is to create a pulley system up here for our toe extensors and to create an attachment point for our muscles coming down. That's the main part of the navicular. It's not necessarily a real, I mean, it's intrinsic, sort of, but it's not an intrinsic part of the arches themselves. Does that make sense? So on those arches, we have a lot of fascial layers, right? And those fascial layers will form those arches. That fascial layer has to have a certain amount of tightness in order to have a normal arch. If it gets too tight, what do we think we end up with? What happens if the fascia in the foot gets tight?
Like flat foot?
Flat foot, or we cramp and get plantar fasciitis, right? So a lot of times when we're looking at patients that have plantar fasciitis, we really got to look at their arches and really, honestly, look at the shoes they're wearing, right? If John's wearing crappy shoes, it's probably going to lead him to get plantar fasciitis. Yes, John.
So can you, actually, I just kind of missed it. So the one that says medial view from the calcaneus to the first metatarsal, that's going to be your lateral longitudinal?
That's just, yeah. So in reality, we don't, so that's why we have it kind of broken up, right? So this here, right? So if this is my first metatarsal is on my medial side, right? So this would be my medial longitudinal arch and then my lateral longitudinal arch as well. But for most questions you're going to get on it is just going to talk about the longitudinal arches. It's not going to separate them out.
Okay.
It's just going to talk about either longitudinal arch going this way, which kind of humps the foot up like this, or that kind of transverse arch, which kind of makes the foot curl, if that makes sense. So you create that kind of cave. So we have the longitudinal going this way, right? The two longitudinals that are lifting up the foot, and then we have this, which creates the cave. And that helps then when we plant down to kind of get that bounce back of the foot and the transfer of all those ground forces.
Okay, thank you.
Yeah, no problem. I told you the foot and the ankle are complex. There's just no, I mean, the foot, the ankle, the wrist, and the hand are just complex. There's just no other ways about it. So looking at, remember I said, we got all this ligaments and fascia. Again, look at all this just poop is the best way I can put it. There's so much here that goes along with it. We already talked a little bit about the spring ligament, right? We've got the long plantar ligament, the short plantar ligament, the plantar fascia. We also got the plantar aponeurosa, which is a layer of really kind of thin, fine fascia that allows those muscles to kind of glide on. So there's lots of stuff in this foot. My main point of showing you this is just shows you how complex the structure of the foot is. I mean, like, when I look at this, again, I'm just back to the fact that, to me, this is really showing how amazing the body is that we're designed this way, right? And it really gets complex if you ever actually get a chance to, and I'm not saying go out and dissect a cat, but if you ever did dissect a cat and looked at the way this is laid out on a cat, it really kind of shows you that this main job of all these ligaments, the plantar ligaments, you know, the spring ligament, the plantar fascia, is to create that arch to allow for that jumping motion or the spring motion of the foot. Yeah, it's all holding our entire body weight, right? That's kind of amazing. And the thing about that, Amanda, is, though, in reality, all these ligaments and stuff that we have also exist in our hands, right? So theoretically, we could, I mean, in theory, train our hands to walk on them because they're not all that different from our feet.
This is off topic, but I was like watching a video of people that are born without arms, and
Yep.
they do everything with their feet. Like they eat, they dress their children, and I'm just like, that's evolution.
Right.
It's crazy.
And it is, right? It's just kind of amazing that you can do, well, and I've seen people that are born without legs that walk on their hands, right? I've seen them where they can just literally walk like it's you and me walking. And you're just like, blows my mind to think that somebody could do that, right? And think of all the upper body strength that requires to kind of walk on your arms too. And then I also think about what all the fine motion control requires for people that are born without arms to use their feet to do everything, right? I've literally seen people pick up a spoon and take a spoonful of soup up to their mouth with their foot, and you're like, how did you do that? I wonder if they can use chopsticks. I've never seen that. I'll have to look to see if the video has that. If you can use chopsticks with your feet, you are next level skilled. Because I can't use chopsticks with my hands. All right, for muscles and ankles of the foot, you are responsible for knowing, again, attachment sites, origin, insertions, and actions of the following muscles primarily for your boards. Before I go any further, I have to beat this concept into your head of extrinsic versus intrinsic. Because this is going to come back to play when we get to the hand as well. Extrinsic muscles originate outside of the foot. So intrinsic muscles exist solely in the foot. You see what I did there? Anyone get that joke? No?
Yeah.
Okay, appreciate it. This is key. So basically, most of the muscles of our foot are extrinsic, right? Because our flexors all start up on our legs, our plantar flexors all start up in our legs, you know, all of those muscles, you know, gastroc soleus, plantaris, tibialis post, flexor hallucis longus, flexor digitorum longus. All of those muscles start up here in the leg. That's what I'm going to flash forward to here in a second, Anthony. I'm going to just jump forward just real quick and brief. When we get to the intrinsic muscles, they all exist in the foot themselves. Okay? So the primary intrinsic muscles, right, are my interossei muscles and my lumbricals. So my interossei and my lumbricals. Interossei meaning between bones. And my lumbricals. I'm going to give you a clue here that my instructor didn't give me that made my life a whole lot easier when I realized this. These are the intrinsics of the foot. So those are my intrinsics. Guess what the name of the intrinsic muscles of the hand are?
Same.
The same, the interossei and the lumbricals. So that's the good news. Once you learn one, you've learned both the hand and the feet, because again, the hand goes with the foot goes with the hand. There is this weird one, the quadratus plantae, that is technically considered a intrinsic foot muscle, but pretty much rarely. Same thing with abductor digiti minimi. For the most part, when we talk intrinsics, these are the muscles we are talking about, the lumbricals and interossei. They are responsible for a lot of our kind of weird motions of the foot that allow us to curl our toes, that allow us to create an arch. So when your intrinsic foot muscles get weak, a lot of times that will lead to a collapsed arch. So that would be where the arch just kind of flattens down, right? So there are 4 different layers: deep, shallow, deepest, right? But if you look at this, I always think when I'm looking at these muscles, their interossei, right, are these little muscles that go between the bones and hold the bones together, right? And then I've got my lumbricals out here that kind of lay over my fascial layer. Again, most of them do most of the work themselves. They do kind of motions that go like this with the foot and hand, right? The lumbricals of the hand allow your hand to do this. They allow that motion in there kind of at the carpal metacarpal joint. That's kind of the lumbricals motion. So that's the interesting part about the Riley. Great questions. The Riley asks, are the interossei like extensors and flexors? There are both plantar and dorsal interossei and plantar and dorsal lumbricals. So they're on both sides of the feet. The main job, like I said, a lot of their job is to do stuff like this of the foot. So opening and closing, so doing abduction and adduction of the toes. And also kind of curling that foot so that you can make that kind of cut motion, if that makes sense. The main thing the important thing that you need to get from me talking about this is you need to know what the intrinsics of the foot are. The 2 primary intrinsics are the interossei and the lumbricals. And that if they are weak, you end up with foot collapse where you get that collapsed arch. Those are we can go on months about the interossei and the way they work and blah, 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 but I'm not even going there because we're not a foot specialist here. So if I have somebody with a collapsed arch and I start working their lumbricals and interossei, you can recover some of that arch. And there's a lot of studies out there. There's a lady that was working on research over at doctor over at UNLV that was working on research about returning people's arch when they have flat feet. And she had really good results by just strengthening those interossei and honestly getting rid of shoes. She had switched a test group over to whatever, I think they're called the Vibram shoes or something like that, the ones that have the little toesies and really don't have much of a surface on them at all. And when she switched them over to it, she noticed that over time, over a couple of months, the person's arch started returning. Which to me is kind of, I'm like, wow, that makes sense. Why would we maybe have lost our arch? Maybe because we've been walking around shoes so much that our foot no longer needs to do that spring because we put softer and softer materials in our shoes, right? Like every time I see those Skechers commercials for the, oh my God, it feels like you're walking on pillows of your feet, the memory foam Skechers commercials. I'm like, is that really a good idea? I don't know. Like, is really putting a lot of cushioning in our shoes helping us or hurting us, right? Maybe Kyrie Irving hurt his ankle because he had too much cushioning in his shoes and his foot got weak. Possible. Let's all work. Exactly. I'm okay with being hippies to a certain point. As long as we wash our feet. That's the only thing I'll caveat there. you will find Mr. McKeever hates feet. Chris, like, absolutely not. I absolutely hate feet. I just hate them. They're disgusting. So again, just kind of knowing all these muscles. I'm not going to go through them because you've already gone through them as well. Chris is like, I hate them as well. And there's a whole subset of people that really like feet, Kersey, just to let you know that. Like, abnormally like feet. Just go on to some of the websites that exist out there. No. All right. Let's look at some common ankle and foot pathologies here. Shin splints, medial tibial stress syndrome, really common. Key thing to understand here is, and this is really important that a lot of people don't understand, if you do not rest when you have shin splints, the key treatment for this is rest, ice, compression, and elevation, right? So our RICE. If you do not rest and do not take care of these shin splints by resting them, you can actually cause bone damage. So, you know, when I came up through sports, when you got shin splints, they used to tell us, just run through them. I don't know if any of you ever heard that. Just run it off. You'll be fine. Right? Exactly. And Joe's like, I got microfractures from it. That's exactly what can happen. Right? I didn't run cross country, but I did do one semester of track, or not semester, but whatever, season of track back in high school. And they're like, just run through your shin splints and you'll end up with microfractures, like Joe said, right? So rest is key when you know the shin splints are occurring. Rest them, ice them, they will recover, right? You've stressed the bone and the interosseous out a little bit. Let it rest, it'll recover, and it can come back stronger. Pes cavus versus pes planus. Pes cavus, high arch. It forms a very big cave. Pes planus is also known as what? Flatfoot. Yep. Or otherwise known as Mr. McKeever. Just joking. I am a pes planus by far. Varus Valgus is a big problem that occurs where the distal end of the toe, of the big toe, their hallux, gets pointed laterally, right? And you end up with a big old nasty bunion out there, right? Look at this. Doesn't this toe look pretty? I found the nastiest picture I could find. I was like, I Googled nasty foot photos. No, just joking. I didn't do that.
And also rheumatoid arthritis going on as well.
Yeah, I'm guessing that one's probably got some RA as well. Yeah, 100%. And also some, look at this. We also got, you know, some guys we don't want to invite to the party, but they're a fun guy. See what I did there? Right? Yeah, he's got some foot fungus going on. All the toes kind of have some fungus going on as well. I wouldn't doubt that this actually is a fungus infection too on the foot. Hammertoes occur. He must be a fun guy, exactly, right? Hammertoes occur when the PIP and the DIP kind of get messed up. So when you have hammertoes, right, PIP is the proximal interphalangeal joint, so here, and DIP is out here. So a hammertoe occurs when your toe kind of looks like this. So you end up with a flexion of that PIP joint and an extension of that DIP joint. I think this is probably a really good, you can see how it's kind of flexed and then extended. And guess what? Yeah, Lamisil is big for that guy, right? When you have hammer toes, you can also get hammer finger, and it's the exact same thing. Turf toe, we got a picture coming up of, I think in the next slide, if I remember correctly. Got some turf toe going on where we end up with some problems with the toes. Ankle sprain, that's a really bad ankle sprain. Look at that, how pretty that is. So this is my lateral aspect of my ankle. If it's a lateral sprain, that means it's a what type of sprain? Inversion sprain, good, yep. And then when we get out here to the ankle, we can end up with what's called either trimalleolar, bimalleolar fractures. So this is an example of a trimalleolar fracture because what they say is the inside of the tibia has a little bone that we don't call a malleolus, but technically is a malleolus. So if we have a trimalleolar, we have a lateral tibial fracture, a medial tibial fracture, and that malleolus of the fibula snaps off. A bimalleolar is just a two-side malleolus that gets snapped. You'll see a lot of those in car accidents. Why do you think that breaks during a car accident?
Pressing the
What?
brakes.
What's that?
Because we're pressing the brakes.
Right, you stomp down on that brake and you've got that foot nice and tight and then somebody rear ends you. Or you hit somebody from the front end and the front of that car jams up into your ankle. It's an approximation from the crash. So again, a bimalleolar is just the two malleolus. Two malleoli. So my tib and my fib malleoli. A trimalleoli is my tib malleoli, my medial tibia as well, and then my fibular malleoli. So if you look in this picture here, I've got a little bit of a fracture on the inside. Let me clear my drawing there a little bit. Eraser, because I drew all over it. If you look here, I've got a fracture of my medial tibia, my lateral tibia, and my malleoli of the fibula. Does that make sense? Right? And that by far is really nasty. I had a friend that had this type of a fracture. I'll have to see. I've got the x-rays somewhere. I'll find them. Maybe I'll find them for tomorrow. Big guy, probably 500, 510 in weight. And he got rear-ended by a tractor-trailer truck. And he saw it coming, so he stomped down on his brake and had his foot flat. And literally this part of the tibia, when it broke, shifted all the way up his leg. And he had to go through months of rehab. Good news for that is it made him also realize he had some unhealthy addictions to food. And he went down, I think the last I checked him, he's down to like 300 pounds. So, you know, good for him, right? 300 pounds still isn't the healthiest. But when you're used to being over 500, 300 is better than that, right? All right, arthrokinematics of the joint. Open pack position. So the position of mobilization is in, changing cameras real quick, a little bit of dorsiflexion. So if my ankle neutral is there, about 10 degrees of 10 degrees of plantar flexion, and then kind of resting midway in the foot. What I like to think about open packed is if I'm sitting on a bar stool and I just let my legs kind of dangle below me, the way my foot kind of rests is my open packed position. It's just kind of where the toes kind of point a little bit downward and the foot is midway in the foot. Closed packed of the ankle is full dorsiflexion, so pulling up as far as you can. I cannot mobilize my ankle at all. If you look, if I'm dorsiflexed like that. If you have a fracture of the ankle, guess what position they're going to cast you in? Full dorsiflexion, because that's the most stable position, the closed pack position of the ankle. The good news, I'm not going to make you memorize open and closed packed of the toes. Thank you. You're welcome. Because it's pretty rare that we mobilize toes, to be 100% honest. In a capsular pattern, if we think that we have a capsular pattern, if the patient is limited more in plantar flexion, so more in plantar flexion than in dorsiflexion, it's probably a capsular pattern. So if their problem is I can't push down, there we go. I can't push down on the gas pedal, it's probably a capsular pattern of the talocrural joint. Most people are limited in dorsiflexion. And most of the time that's because tibiant's too weak. right? But if the patient's limited in just that plantar flexion, but they got pretty good dorsiflexion, it's more than likely a capsular pattern. At the subtalar, if they're limited more in inversion than eversion, that's a capsular pattern. So if you've got somebody at the foot that is limited both in plantar flexion, both in pushing down and in inversion, you have a pretty good sign that that person's got a capsular pattern of the ankle. And at that point, we are going to do what to that ankle? What do we do for capsular patterns?
Mobilize.
Mobilize. Yeah, right. We're going to get in there and really work on those joints and mobilize them. Now, if I've got inversion and dorsiflexion loss, does that mean I don't have a capsular pattern? Not necessarily. It could be that my subtalar is capsular and my talocrural is muscular. So that's where we kind of have to play the game of, is it chicken or is it egg? Or is it both? Right? How does the egg make the chicken? Well, you feed a chicken an egg. I'm just joking. Don't do that. That's mean. So again, if I have a problem here where I go, oh, well, I've got plantar flexion limitation and I got inversion, I'm going to come up here, put them at about 10 degrees of plantar flexion, the foot midway between it, and I'm going to mobilize that joint. And honestly, when we do this, when we practice this, this is probably one of the weird ones that a lot of people like. I don't know what it is about ankle mobilizations, but they just feel good, I think, because we don't do a lot of exercises with our ankles. And when we mobilize them, it just feels good. Range of motion. Dorsiflexion. Need 20 degrees for full. Plantar flexion. We should have at least 50. I will guarantee you will probably find that some people only have 10 and they have a lot of plantar flexion because that's kind of the way we are. Inversion, you should have 35 degrees. Eversion, you should have 5. I put these subtalar inversion and eversion numbers on here, not because I'm going to question you on them, but understand that 5 degrees of that inversion and 5 degrees that eversion occur at the subtalar joint itself, even though you look at that subtalar that sits on the calcaneus and you wouldn't think there's a lot of motion there. At the first MTP, you should have about 50 to 70 degrees of extension. This is a weird one. Like, look, they got a range for the toes. And then a flexion, you should have 30 to 45 degrees. That's considered normal so that you can have fully functional kind of foot motion and gait. More importantly than these ranges of motion is functional range of motion. In order to walk, you should have about 10 degrees of dorsiflexion and about 30 degrees of plantar flexion, 15 to 30 degrees of plantar flexion. For going up and down stairs, the one thing I always remembered for up and down stairs is that it's equal. You kind of want about the same range of motion, right? 15 to 30 of dorsa, 15 to 30 of plantar for going up. In descending, you want full dorsiflexion so you can pick the foot up and you can roll through on it. And you need about 40 of plantar flexion so that when you reach down for the stair, you can find it. Why is this important? Well, this is especially important for patients that have had surgery, right? Kind of the final things for goniometry and for manual muscle testing. I'm going to try to slide out here. I'm going to turn this a little bit so it's not getting the monitor. There we go. For plantar flexion and dorsiflexion, we are going to line that goniometer up out here on the lateral aspect of the foot. Your fulcrum for dorsiflexion and plantar flexion, going up and down, is going to be the lateral malleolus. Fixed arm is going to go along the lateral midline of the fibula. So it's going to go basically the lateral midline of your leg. The movement arm is going to go parallel, meaning it's going to run a line straight, running parallel to it, to the lateral aspect of my 5th metatarsal. So I'm going to come out here and find my 5th metatarsal, and it's going to run right along that. So I don't like using a big goni for this. Let me get something I can lay on this to use as a something to put my foot up on. Right, so if this is my foot, I take my fixed arm here, it's gonna line up with the lateral midline of my foot. That fulcrum is lining up with my lateral malleolus. And that movement arm is gonna line up with the distal fifth metatarsal. Actually, let's use this. This is a little thicker and it's not gonna blunt. For inversion and eversion, when I'm sitting here going inversion, eversion. The fulcrum, if you read the book is going to say the fulcrum is midpoint between the tibia, the distal tibia and the distal fibula. In that area, you have what's called the anterior sulcus of the foot. A sulcus meaning kind of a divot. That is what they're talking about when they say that. If you kind of come down your foot, you have a kind of hollow area there between your bones. That is going to be my fulcrum for inversion, eversion. My fixed arm is going to line up with the midline of the lower leg. And my distal arm is going to line up along my second metatarsal. So if I go into eversion, it's going to go that way. If I go into inversion, it's going to go that way. It's sticking to my sock. And again, you're not going to have to take goniometry of the toes. I'm not going to make you do that. If you do that in the clinic, they're in the book, but it's very rare that you do goniometry of the toes, just being 100% honest. So for manual muscle testing, you just have to do dorsiflexion, plantar flexion, inversion, and eversion. And we'll practice those a little bit tomorrow during class. So that is it for this little 15, 20 slide lecture. Any major questions? Other than something was a foot. Not at the moment, Riley says. The foot's complicated, but there's not a ton of data there, right?
I have a question. Where do we stabilize when we're measuring range of motion for inversion and eversion?
So when I'm stabilizing, let's switch cameras here real quick again. When I'm stabilizing, I'm going to use, where did I put my goniometer again? There it is. And I don't like using this big goni because it doesn't, when I stabilize, when I put this fixed arm on my foot, once I get it, I'm going to stabilize across the tib fib so that I can't cheat. And the only motion I can get is that, because otherwise I can kind of slide the leg and make it look like I've gotten more. So I'm going to lay my hand right over kind of that proximal arm that I have, or the fixed arm, and that's where I'm going to stabilize. Does that make sense?
Yeah, thanks.
Yep. And it'll make a lot more sense once we get into practicing all of these as well.
Mr. McKeever,
Yes.
I have a question from the Kahoot.
Yes.
Okay, so it says your patient has 5 degrees of extension lag and 105 degrees of flexion at the knee. This would be documented as, and it says 5 degrees dash 105 degrees. And then there was one before it, and I wasn't sure why there was a neutral for the other one, and then there's not a neutral for this one. And I think it has to do with the lag, but I was unsure.
Yeah, so whenever you see lag, especially when you say extension lag, it means the patient can't achieve full extension. So if I had a normal patient for the, like, whether it's the knee, the hip, whatever it is, and this is more about just writing out the note, right? If I had a normal patient, like, so I'm gonna use my elbow for an example. If I have 5 degrees of extension lag of the elbow, I'm not able to fully extend the elbow.
Okay.
So that means you're going to go from where I start, which I'm starting at 5. Normally you'd go start at 0, right? Because out here is 0, I have nothing.
Okay.
I'm stuck here, so I start from 5 and go to whatever my flexion range is.
Okay, so lag is always going to be written with just the 2 degrees.
Yes. Now let's say I had hyperextension
Okay.
and say I could go past 0 and I got 5 degrees of hyperextension.
Okay.
Then we would write it 5, 0, because I can get back to 0,
Okay.
and then the flexion.
Okay. And then so if there is no hyperextension, it's just going to be the 2?
Yeah, it's just going to be 0 to 120 or whatever.
Okay. Okay, that makes sense. Thank you.
Yeah, no problem. Yeah, Amanda says on page 35, I think there's some good examples of it. You're right.